Okay, so this is just a primer for what to do in the inpatient and ICU setting. This is not going to be a comprehensive, confusing and exhausting review. So just the inpatient aspects of ILD or diffuse parenchymal lung disease. So objectives are just to identify them, how to approach them, and manage the acute exacerbations with some guideline-aligned interventions, as you can hear. All right, so what are ILDs and why do they matter here? They're a pretty common group of disease pathologies. Um, if you want to compare with COPD, it's like 1/3 in incidence and prevalence, COPD being far more common. But there are 200 different types, which we have to distill down to what's relevant and what we have to do. And commonly in the ICU, non-specific symptoms, hypoxia, and infiltrates, and know when to intubate and when not to, because intubation carries high mortality. So there's many, and this is not to go over, but just to, what happened? Okay. There are many, but not to go over everything and confuse everyone. So I'm gonna just start off here with a basic anatomy. Basic anatomy here just to give a sense of what we're looking at. So when we talk about a pulmonary functional unit, like a hepatic lobule would be in a liver, this is called a secondary pulmonary lobule. It's not the alveoli that are the functional units, but the secondary pulmonary lobule is. And the center of that comes terminal bronchiole along with your arteriole. Okay, and that is surrounded by septae, which are the type 3, type 4, type 2 collagen and elastin, and from that alveolar acini and ducts. Multiple. There's so many. This is just an enlarged view. So the alveolus is not the functional unit, but this secondary pulmonary lobule is. So arteriole and terminal bronchiole in the center bring in the oxygen and the deoxygenated blood, and then diffuses outside and then collected at the pulmonary venules and lymphatics, and then pours back into the left heart. So this is the zone where the collagen, elastin, and cellular debris can accumulate in disease states, specifically this category of disease. So diffuse parenchymal lung disease or interstitial lung disease is predominantly here where you have deposition of inflammatory either neutrophils or eosinophils, or that's the acute part, and then fibrosis, which is fibroblast activity based on cytokine, interleukins, all of them hammering out that inflammation process in a chronological basis. The others being you can have coexistent disease with maybe airway, maybe just airspace, maybe pleural, but this is our point of interest for today. If you know a cause, then basically you just stop that and treat it accordingly. So if it's rheumatoid arthritis, immunosuppression. If it's drugs and toxins, stop it, give it time to heal and recover. Steroids are a big portion of treatment, and antimicrobials, empiric, are a big portion of treatment as well. So the bottom line is there's not much to focus on in an inpatient world. The 80 to 90% of the workup, chronic treatment, chronic management is all outpatient. The 10% of this disease envelop can be seen in inpatient, and that's just where you don't want to miss any major aspect of treatment, don't want to miss any red flags, and know when to call consults and think of biopsy or anything specific. So idiopathic interstitial pneumonias, which just don't have any defined cause. So there's plenty of types. We don't need to know all of these for inpatient and ICU purposes. And when we know the cause, it's either autoimmune from all the things we know, or exposure related, like occupational exposure or medication, radiation, something like cocaine or heroin, infectious, RBILD, smoking associated. And the rare ones that don't put an effort on remembering, because this is all board question level, I do see a lot in pulmonary consult, but there is the answer for you in the ICU. Call a pulmonary consult and try to get to that specific treatment if you can. And then granulomatous diseases like sarcoidosis. So distilling that into a clean cheat sheet, known cause, unknown cause, granulomatous. These are the three major headings, and everything can be thrown into unclassifiable at the end. So what are we looking for in outpatient versus inpatient? Because 80 to 90% of these are outpatient, because as you can see the tempo of progression here, most of them are chronic. Most of them are chronic. But the ones that are acute and subacute, you'll see here. So like a person who's desatting, breathless, looks like they're dying, the floor calls you for a consult, you bring to the ICU, you see an ARDS-like picture. The pathology there is diffuse alveolar damage. So the first column here, pattern, is either radio, pathological, or clinical. So how does it look clinically, or is it radiologically fitting into one bucket or clinically into one bucket? So UIP is the radiological or pathological pattern. It stands for usual interstitial pneumonitis. NSIP is non-specific interstitial pneumonitis. OP is organizing pneumonia. RBILD is respiratory bronchiolitis, and DIP desquamative. So you don't need these per se, but these can also undergo acute exacerbation. So you need to know how to deal with that acute exacerbation. And then anything can be the etiology when you know the etiology. When you don't know the etiology, it's just called idiopathic. So if you have a UIP pattern that a rheumatoid does, so that CTD caused UIP, if you don't know the cause, it's IPF, or idiopathic pulmonary fibrosis. Similarly, if your inhalation of, say, mold caused an NSIP picture, that's mold-related NSIP. If there's no cause, that's idiopathic NSIP, right? So DAD is what you'll see in the ICU. And if it's idiopathic, it's called AIP, or acute interstitial pneumonitis, which is, if you don't know the cause of ARDS, that's it. If you know the cause of ARDS, that's ARDS. The treatment is the same. First of all, remove the offending agent or underlying causal treatment, then lung protective ventilation of all the types that we know. Okay, so just to show a few examples. So this is our AIP. If there's a cause known, it's ARDS. So diffuse infiltrates, be it consolidative or ground glassy. And on the pathology, it shows up as hyaline membranes. So hyaline membranes are basically dead and dying fibrinous depositions on the tissue. Some other, you don't need to remember this, but just for contrast's sake, this is lymphocytic infiltrate. In a sarcoidosis, this would be a granulomatous infiltrate, and this is what a Sjogren's patient would show. And this is just fibrosis at the end, where this is a lot of deposition of fibroblasts that you can see on the corresponding image. So this is so like simple in terms of treatment. Either it's immunosuppression, or it's avoidance, or it's cessation of the insult, and sometimes antifibrotic. So that's where a pulmonary consult should be sought out. And what are the relevant ones that end up here? So IPF, acute exacerbation of IPF, any connective tissue lung disease, any hypersensitivity pneumonitis, any drug-induced ones, or advanced sarcoidosis like BED29 that you see here. So I'll go through a few images just to show what looks like what typically. So IPF is the typical UIP, or usual interstitial pneumonitis. It has a predominant pattern of apical to basilar gradient, so the bases will have more. It's got this reticular pattern with traction bronchiectasis, so the airways being pulled apart causes them to dilate and malfunction. it's not your bronchiectasis from CF. That's just airway disease causing bronchiectasis. But this is this is the parenchymal area pulling the airways apart. And then honeycombing is the pathognomonic feature where these cystic spaces are stacked on top of each other. So if you do have honeycombing, this is a recommended area where we don't even need tissue diagnosis. That's UIP. And if there's a cause, that's UIP due to that cause. If there's no cause found, that's IPF. And this is very common. Like I said, it's around estimated to be 1/3 of COPD prevalence in overall statistics, and IPF is a big 1/3 of that bucket. And like multiple sclerosis in the neuro world, you have different patterns like continuously progressive, remitting, relapsing, all of those. Similarly, you can have IPF that is rampantly decreasing with lung function and hurtling towards death. You can have slower progressions that live quite a while, go undetected for quite a while. Some that have steady decline in a 5 to 6 year median, and any exacerbation really increases the mortality, So an acute exacerbation has a definition. It's an acute clinically significant deterioration with new widespread alveolar abnormality, but you do have to exclude pulmonary edema, which is reversible. And this is the usual IPF bucket, undergoes around up to 1/5 of people exacerbating per year. And this is a variation because different studies found different numbers. And these are usually the cause of death, and median survival after an acute exacerbation is poor. There's a high in-hospital mortality, right? And steroids don't really help, but are used. They don't harm either unless you're dealing with other issues like rampant infection or bleeding or any of that. Antifibrotics that are used in the outpatient land can continue, but nobody's going to start antifibrotics. And in the outpatient world, when they are used, they prevent this exacerbation phenomenon. And this was a case we had in fellowship. So at the time of diagnosis, this 62-year-old female was just showing signs of reticular changes right here. And we have to monitor the context of disease onset, the tempo of disease progression, rule out every other factor. That's why if you see my notes in pulmonary consult and see me ordering like 100 serological markers for connective tissue related ILD, that is because we need to rule out that those as a cause, because those have different pathways for treatment, including immunosuppression with steroids in the short term and some form of immunosuppression in the long term, be it methotrexate, be it cyclophosphamide, be it rituxan, be it azathioprine, whichever that disease state has proven data to respond the most to. And that is variable to change, obviously. And functional assessment with PFTs are always important. But this person from 12-month onwards started having one thing after the other, started to feel crappy. And as you can see, this is the typical acute exacerbation of pre-existing IPF. So when you see a CT like this in an ICU, which is all too common, my first step is to look back. Do they have prior CTs to compare and see the chronology and tempo of progression? This is just for fun. You're not gonna like need this in a day-to-day basis. It's a very rare disease, but there are cystic lung diseases too, like big cysts, and amongst them, the most common because it's smoking related and cannabis smoking that too. It's called Langerhans-Sells histiocytosis, but it is a CT diagnosis a lot of times, not even needing biopsy diagnosis. And as the smoking prevalence continues to be rampant, both can coexist. So this is called CPFE, or combined pulmonary fibrosis with emphysema. And some others, like CT-ILDs, affect many places, like I said earlier, not just the parenchyma with ILDs, but also pleura with pleuritis, effusion, pneumothorax, the airways with bronchiolitis, bronchitis, bronchiectasis, pulmonary vasculature, which is very important, pulmonary hemorrhage, pulmonary hypertension, vasculitis, and extra pulmonary systemic symptoms. So for example, RA, it does the ILD, it also does just nodules, it does bronchiectasis, it can do pulmonary hypertension, it can do any other extrapulmonary symptom like joint disease, and you know the rest. Sarcoid, so it is a granulomatous disease state based on the pathology finally. What it is clinically is a multi-system autoimmune origin disorder of unknown trigger. There's some genetic composition with some trigger that is identifiable in a certain proportion of the cases. The granulomas can appear in a wide range of diseases, sarcoidosis being one of the most common, then hypersensitivity pneumonitis being a very common one. Then chronic infections like mycobacterial or fungal are out in the community all the time. When I biopsy this in a transbronchial fashion or a VATS fashion, the granulomas determine the disease and is it caseating? Does it have any other systemic symptoms? Like if I see a sarcoidosis concern, the first step I do is look at other places where a biopsy might be easier. Like, do they have a parotitis? Do we have a uveitis? Do we have a skin lesion that looks like erythema nodosum that may be much more easier to biopsy without me going for an EBUS right away? And then once I do find sarcoidosis, it doesn't even mean treat all the time, right? These are outpatient assessments that we do. If we have a rock solid PFT and just, bilateral hilar adenopathy, which is stage 1, I don't need to treat this person. When there's a drop in PFT or symptoms like cough, shortness of breath on exertion, or something else, then we start treatment. And that is, again, immunosuppression in the form of a course of steroids first, then continue that with some dedicated form of steroids suppressing immunosuppressant or DMARD. Suspecting it in a new, fresh patient, hypoxia, bilateral infiltrates, the usual bread and butter of our ICU, ruled out, some autoimmune clues, and then open up your prior CT if available. CT is super important. ATS says biopsy is often unnecessary and tagged along with high mortality. So don't pursue biopsy. BAL is fine for ruling in or out infection that can be concomitant. And if you do have biopsy capability, then transbronchial is superior to surgical in the mortality terms. So I have done a transbronchial lung biopsy in inpatients for this purpose because that sometimes gives a definite question, do I go in this direction or that? And BAL, like I said, to rule out infection, and sometimes in diffuse alveolar hemorrhage where the management changes by you going for pulse dose steroids, which is a very high dose, 1 gram per day for 3 days and obliterate any immune response kind of attempt, go big or go home attempt. Transbronchial only in supported and experienced centers, surgical, please avoid. So we talked about this, acute worsening, new ground glass or consolidation, high mortality. Some studies say 40, 50%. Some studies go up to 96%. And what are the triggers? Treat them, support them, rule out infection or alternative causes like PE. Steroids, wide range of steroids. You can go for pulse dose if you can justify an autoimmune underlying theme. It's a 3-day, 1 gram per day of solumedrol, but usually 1 mg per kg body weight of prednisone or solumedrol equivalent is usually okay. Multiple studies have done different doses. There's no definitive data on this dose is the best. Just remember long-term steroid consequences and address those, like pneumocystis prophylaxis, PPI prophylaxis, bone and joint issues like elderly, delirium, all of that. And avoid intubation if possible because there's high mortality in this IPF population at least. Continue their outpatient antifibrotics if otherwise not contraindicated. PPIs are not routinely recommended. Again, avoid invasive diagnosis, and a big deal, call palliative. Call palliative early because this is, you're seeing the 10% that are quickly diminishing and they deserve some end-of-life clarity and comfort. Screen for any reversible autoimmune causes. When there's hemoptysis, do a BAL to rule out DAH. Diffuse alveolar hemorrhage is a distinct clinical term when there is, if you do a BAL and you have a good seal and a good sample return, you have to do 3 separate aliquots of return to see are they progressively getting bloody. And if that is inconclusive, send that sample to the lab and specifically ask for hemosiderin-laden macrophages. And then immunosuppression when you're able to. Fibrotic hypersensitivity pneumonitis is extremely common, and also PPF is progressive pulmonary fibrosis of any other origin rather than IPF, but treatment is identical. This is repeating the same: oxygenation, conservative fluid, avoid unnecessary steroids, but empiric steroids are needed a lot of times, and all the early pulmonary and palliative consults. Transparent referral, if early in the course, do it. If it's a 60-year-old guy with an IPF exacerbation that he's dying, pulmonary consult, and then referral for transplant sometimes saves them. And early goals of care discussion. That's it. PV ECMO does put them up on the list, just like pulmonary hypertension gets bumped up for portal pulmonary hypertension, hepatopulmonary hypertension. Yes, it does bump them up the list. It just then depends on our transport feasibility is okay, is the accepting hospital comfortable, or do they even have beds? That's always the question.
I think too, though, it depends if they're not.
Unlikely, but they do get bumped up. They do get bumped up. They do get bumped up. We've had the exact same thing in COVID times at Upstate, where we had a lady on VV ECMO, then bumped up because they were on ECMO, and they went to Miami, of all places, and got the transplant.
Is there much data on like this? Because I feel like there's certain things we don't cover until. Can't detect it rapidly. A lot of people have a lot of misinformation.
Yeah. It's not really specific for ILD per se, but any immunosuppression when there's diffuse bilateral ground glass opacities, and your BAL is of value there. If you have an ability to bronch them, serum LDH, sputum for pneumocystis, antigens for pneumocystis, fungal invasive markers, and it just needs a high degree of suspicion, really. Chronic prophylaxis is an easier decision. Active treatment is a harder decision. I don't know of any data of pneumocystis specifically.
I mean, our experience, I feel, can't think of something.
Yeah.
Hey, Subrat. You guys can hear me?
This guy that you had that looked like a chemo pneumonitis resulting in DPLD. Yeah. Yeah. See, there's so much poor prognosis. That's the bottom line. So, and really don't feel bad, because the 80 to 90% who have decent prognosis, we're managing them outpatient. We're getting them the care they need and early transplant referrals when they have that scenario. But like when it's time to die, this is where they end up, and we only see that and feel like, oh, this is a death trap, right? There's nothing to do. But this is a small chunk of that population. Extremely poor prognosis at the end, and hence to make their suffering easier and get them palliated is a big deal. So
you're not doing pulse steroids.
Start off with like a dose or two of 125 and then 60-40 BID, something like that, and then depending on the response to taper down for the side effects, glycemic control, and all of that. Empiric steroids also helps to tell us, is this a steroid responsive entity? Because in the NSIP land, there are acute cellular ones, right? So NSIP is non-specific interstitial pneumonitis, where there's a lot of acute cellular infiltrate, a lot of neutrophils. Eosinophilic pneumonia falls under this. So slamming them with steroids in that acute phase really turns them around. So why be shy in that regards, right? I mean, what's the damage? It's a very short course of steroids. You're not going to give them pneumocystis right now, especially if it's less than 20 days and less than 20, like mg per kg of prednisone equivalent for less than 20 days, go for it. And then if you're needing that excess of 20 days, add on the Bactrim. Osteoporosis and GI ulcers happen much more long-term, so this will kill them before osteoporosis will.
Yeah, all and we see cell counts.
Mhm.
Do you think it changes things much or
Treatment is steroids on both regards, right? Eosinophilic pneumonia with a bunch of eosinophils on that versus sarcoidosis with the high lymphocytic predominance, especially CD4 to CD8 ratio elevated up towards that 4 range. Hypersensitivity pneumonitis with a lymphocytic infiltrate, but CD4 CD8 ratio on the low range. All three need steroids. So treatment wise, right? I mean, it's just steroids if unless contraindicated, empiric antibiotics, call a consult to see if there's any additional specific issues that the consulting service can add, including look up prior images and find out the underlying cause. But the BAL predominance is, if you can do it, great, it helps. But the acute stage, is it even reliable is the question. So if they get better, if they're discharged, I see them in clinic in a month, and then I plan an outpatient bronch, that will be much more valuable because now they're no longer on steroids. I can get a clean sample that is representative of their disease pathology. Antifibrotics are two, nintedanib and pirfenidone. They were initially only for IPF where we didn't know the cause, but now for every element of progressive pulmonary fibrosis defined as there is fibrosis on imaging and there is PFT worsening, delineating both anatomical worsening and physiological worsening. If you have tolerance, because these are toxic meds, nintedanib and pirfenidone both are tyrosine kinase inhibitors that need hepatic metabolization. Nintedanib is easier to take; it's twice a day, small pills. Pirfenidone is like horse pills, like 3 pills 3 times a day. It's just ridiculous, and there's no third agent. It's just we've been forever in the wait for, yeah, give us something easy. But those have hepatotoxicity, so we have to monitor liver function, and then a lot of like diarrhea, like GI distress, and then those are the common ones. Then uncommon, you can have drug interaction, idiosyncratic hypersensitivities, many things, right? So they do have effect for those people who do tolerate them. So an IPF person untreated, say, has a median survival of 5 years. Treated, they can go up to 10 years easy, and also reduce the rate of exacerbation. And what is that benefit? It's first of all reduction in rate of loss of FEV1 and FVC by about 150 mLs per year, which for us is not a big deal because we're living around 3 to 4 liters of FEV1. But for these guys, we're living around that 1 liter. That 150 ml is a huge deal. And that translates to higher 6-minute walk distance, higher exercise tolerance, taking a flight of stairs, doing their groceries, all is a win. Now you supplement that with, obviously, if they're smoking, smoking cessation, pulmonary rehab, vaccination strategies, all of these bundled together helps patients in the chronic basis. But the inpatient, what we see is all dead and dying mortality high. So, just try to get to the bottom of it. Empiric steroids, empiric antibiotics, palliative early on, some cases of lung transplant early on, and expert consultation, review of prior imagings. Those are the takeaway from today. Okay.
oh, we got hit with the drum. What are ventilator strategies, considerations in IPF?
So first of all, don't intubate them. That's the ventilation strategy. Try to get palliative and make them comfort care, right? Because you have up to 96% mortality in different studies for IPF exacerbation. And even if you don't, it's a 3 to 4 month median survival. Those who do survive and make it a long time, that's why the median is 3 to 4 months, because a lot of them die. But when you do put them on a vent, if it's a DAD acute phase that IPF also can go through, any kind of ILD can go through an exacerbation that is more acute infiltrative with ground glass and consolidative disease. That says there's cellularity, which responds to steroids, hopefully, and BAL to rule out DAH or infection, and then lung protective strategies akin to ARDS management.
I think one of the struggles we really have here is maintaining that lung protection, especially targeting the perfect. Both of these patients we had up this week, anytime the CO2 rose a little bit, cranking up the pressure. So the morning battle, morning turn down the pressures, nighttime pressures go up because they're so stiff, right? Like they often you start seeing the CO2 start rising.
Yeah.
So they often don't have a lot of recruitable on some.
Yeah,
Like, sometimes people like 8 to 10 pounds, they have such heavy units. You can crank the volumes up and it'll look like the volume. Oh wow, I'm getting 500 mils. It's all going into that client volume.
yeah, exactly.
And,
So just a very brief anatomy and physiology of vented airway. So mouth, nose, upper airway, stomach, epiglottis, vocal cords, trachea, bronchi, right upper, middle, lower, left upper, lower. And 23 generations later, the first 16 of which are non-participatory in respiration, so that's essentially dead space. It's just a resistive circuit. Whereas the latter 7, including the secondary pulmonary lobules everywhere, up to the point of the alveoli, that's your compliant or elastance circuit, right? So any kind of vent will deliver air that is pressurized. So that pressure has to overcome first the resistive pressure. So that's P1, and that is proportionate to the fourth power inverse of your radius of that circuit. So for example, a size 6 tube will be much harder to ventilate compared to a size 8 tube. Or an asthma COPD will be much harder to ventilate than a normal person, or bronchiolitis or bronchiectasis or all of that. And then when we go to the compliance circuit, right, if there is good compliance, so compliance is defined as change in volume by change in pressure, and elastance is the opposite or inverse of compliance, right? So the better the compliance, you need lesser of a P2. So that's the second pressure that you need to get the volume. So that is, second pressure is going to be directly proportionate to elastance. How bad your elastance is, the more pressure you need. Or inversely, how good your compliance is, the less pressure you need to get that same amount of volume. However, ARDS, DAD, AIP, these acute killing stages are very, very heterogeneous. So you don't know where your high volumes are going. That's why lung protective volume is a very important concept. You don't want to cause barotrauma or volume trauma in the functional baby lung units. This was the concept in the ARDS from ARMA trial. And then you don't want to cause atelectotrauma by causing repeated shear, strain, and stress of rapid opening and closing. That's why you need to maintain a PEEP that is supraphysiological, and physiological PEEP equates to around 5. So you should have a PEEP of at least 5 all the time. But if there's oxygenation issues, you want to open lung and recruited lung more. So 8, 10, 12, and that is based on that ARMA trial again, where you correspondingly go there. In bivent or APRV, this is inverse ratio ventilation. So you want to keep it open more by keeping a baseline pressure more for a longer time and recruit more and more lung units, right? Where was I going with this? The other things that you want to protect the lungs are driving pressure. You want to keep this less than 15. So the top minus the bottom. So P1 is this airway pressure, P2 is this pressure. So let's say in a volume control mode, this P2 becomes plateau pressure. And in a pressure control mode, this P2 becomes pressure support. The bottom pressure is the PEEP. And then the top pressure becomes the peak inspiratory pressure in volume control, which is a combination of P1 and P2, because P1 is just the airway pressure, right? So we don't really care about the pressure here. We just need to get the flow. But we do really care about the pressure here. That's why keeping the plateau pressure of less than 20, ideally less than 30, but the less towards 20, the better. We want to keep these pressures low for less barotrauma, keep less volume not to over distend the functional units, and keep a good PEEP.